So today we're going to be going through just some basic principles of pharmacology, and this is based off of chapter 4 in your textbook. So the DEA handles predominantly what are considered controlled substances. And they put out this chart where they identify the risk potential for both abuse and dependence of these various medicines. And Schedule 1 is the most potential for abuse and dependence down to Schedule 5, where there's the lowest potential abuse. Anybody that is going to prescribe these types of medicines have to have a DEA license showing that they've been certified to prescribe these medicines. Schedule 1s pretty much have no medicinal qualities. Those are like your heroin, LSD, marijuana, ecstasy. This marijuana could even be up for debate as it's used in medical purposes often. Schedule 2 has a lower abuse potential. This is where a lot of our narcotics fall. Important to note that cocaine does in fact have some medicinal qualities. It's often used after nasal surgeries to help with bleeding. And then as you go down this chart, things have a lower potential for abuse and dependence. Important to note, once you get down to Schedule 4, there's fewer refill regulations and fewer regulations in general on how it's prescribed. But each state has a little bit of a different setup for how you have to prescribe these medicines. And then the Food and Drug Administration is an agency of the U.S. Department of Health and Human Services. Their goal is to promote and protect the public health by helping safe and effective products reach the market in a timely way and monitoring products for continued safety after they are in use. So it's not just once you get FDA approval, you're good to go. They continue to monitor it. An important term to be aware of is bioequivalence. What happens when a drug comes to market is a certain company submits for FDA approval, and once they receive that, they start selling that drug under their own patent for a certain number of years. And they are the only people able to produce that medicine. And they have that patent in order to gain back the costs of developing the medication. But after that patent expires, it can go generic. And bioequivalence is how many milligrams or what dosage of the generic medicine is considered equivalent to the brand name medicine. The FDA also monitors how drugs are marketed to consumers, what indications you can use a medicine for. They monitor what's on that package insert, as well as how the medication is manufactured. Important to note that the FDA does not monitor supplements or herbal products. So these companies that produce these products don't have to prove that they do what they're saying that they do. So another thing to keep in mind is the difference between administration and dispensing. So dispensing a medicine is getting the fill, think of it like getting the bottle from the pharmacy or whoever is giving out these medicines, okay? It requires facilities that dispense to have a DEA certificate on file, okay? And important to note that some states consider dispensing medications as beyond the scope of the athletic trainer. Administration is the direct application of a single dose of drug. So administration would be, I give you a dose of ibuprofen. Dispensing would be, I give you a bottle of ibuprofen to go home and take it yourself. Then going into pharmacology and some of the different dynamics there. So pharmacodynamics describe the actions of a drug on the body, including its mechanism of action and medicinal effect. Versus pharmacokinetics describe how the body acts on the drug. This includes absorption, distribution, metabolism, and elimination of the drug from the body. So a little bit more about the pharmacokinetics. So absorption is how are we going to actually get the medicine into the body. There's quite the variety of routes that we can choose from, and we'll go into the details of these in a little bit. Distribution is then how does the drug move throughout the body. Some medicines are protein bound, some are free. Some medicines are water soluble versus fat soluble, and those properties affect what types of cells they can get into. And also we think about, can it cross the blood-brain barrier if it's a medicine that needs to act in the central nervous system. And the blood-brain barrier is one that we think about an awful lot. And this is just a quick slide. I don't expect you to go through all these different parts and know them really thoroughly, but I just wanted to highlight, you see in this normal blood vessel on the left, how big some of those gaps are. And that allows a lot more diffusion across that membrane. Versus on the right here, this is the blood vessel, and whatever molecule has to be able to diffuse out into these neurons and into this extracellular space. But it's a lot harder as there's tight junctions, there's not those gaps in between. You have to be a pretty specific molecule in order to get across that blood-brain barrier. So going forward, metabolism, that's how the drug is changed from the original in the body. And this occurs primarily in the liver. A lot of medicines, we give them in one form in order to survive the acidity of the stomach. But then once they're taken up into the liver, they're activated and their molecular structure is actually changed in order to serve the purpose that we're giving it to them for. So this is important to note, that if you're giving multiple medications and they all require the same enzyme in the liver to activate them, that's how you get some drug-drug interactions, because they're all fighting for that same enzyme to activate them. And then we think about elimination. That's how we get the drug out of the body. Clearance is a measure of the body's ability to eliminate a drug, and it describes the volume of blood that is cleared of the drug over a given period of time. The half-life is the length of time that it takes for blood levels or tissue levels of a drug to decrease by 1/2. The half-life helps us determine how often that drug needs to be given. If it has a longer half-life, you don't have to take it as often in order to maintain that therapeutic level. Okay, so going through different routes of administration. We always try to pick oral first because it's convenient and the least invasive. Okay. Important also to think about sublingual, which a lot of your anti-nausea meds and some like anti-migraine meds dissolve underneath your tongue. It's nice because they work a little faster that way. Like I was talking about a little bit ago, oral can be difficult because the medication has to be able to survive the GI system. It can't be broken down by the acidity and such. And so that's a barrier to giving some medicines oral. Inhaled medicines, often like bronchodilators and corticosteroids, via those metered dose inhalers. Those are nice because they can work just locally on the lung tissues and the airways to help stop with that inflammation and that restriction without all the systemic side effects of taking steroids by mouth. Sometimes there's medications just for your eyes or for your ears, often used obviously in infection, allergy, diabetic issues can need eye drops. Topical medications are nice because you can exhibit a local effect again versus a systemic effect. Oftentimes topically we use like steroids for skin rashes and such, and just like we talked about with the inhaled medicines, it's nice because it works just locally instead of giving you all the side effects of taking an oral steroid. Transdermal, used a lot less. It's usually a patch. IV is nice because it has the fastest onset. You get to bypass the GI tract, so some medicines that aren't metabolized well, it's better to give them IV. But this is also a big barrier to care because it's not like everybody that needs medication can have an IV all the time. Intramuscular is another option that we use when we need rapid, reliable onset of a drug, but IV access is impractical. One example of this is sometimes we give people IM antibiotics when the oral stuff just isn't enough, but we don't want to admit them to the hospital. Subcutaneous, that's just where you inject right into that subcutaneous fat layer. This is the preferred avenue for self-injected medicines. One of the biggest examples of that would be insulin. Intra Synovial and intra-articular are similar in that Intra Synovial is typically when an anti-inflammatory corticosteroid is injected into the synovial cavity versus intra-articular into the joint itself. These are two routes of administration that are probably a little bit more prevalent in your guys' world than in mine. Ion tophoresis is using like low voltage currents to kind of drive that medicine into the subcutaneous tissues. Often done by physical therapists to help with bursitis, tendinitis, tendinopathy, and even manage scar tissues. So about drug storage, it's important to think about where they are stored. Most drugs are sensitive to temperature, humidity, and light exposure. Most drugs do the best in a cool, dry, and dark place. And you need to check the federal and state regulations for controlling, for storing controlled substances. One of the best things you can do for yourself is get a really good pharmaceutical resource if you're going to be handling medicines. I really recommend using some type of electronic resource as opposed to buying like a book, because new medicines are coming out all the time. We're learning more about the medicines that we have all the time. And so these are the most up-to-date ways to do it. I use Hippocrates in my practice, and I've used Micromedics often as well. So now talking about pharmacodynamics, this is more about how the medications work in the body. So thinking about the mechanism of action, the drug interaction, side effects, adverse reactions, allergic reactions, those kinds of things. A couple of terms to be aware of is an agonist. If something is called an agonist, it's that medicine exerts its effect by attaching to receptors in the body, causing stimulation of that receptor. So an agonist turns on the receptor. An antagonist, on the other hand, turns off the receptor. So the antagonist blocks other chemicals or agonists from binding to that receptor. So we think about the indications for different medicines. The FDA approves the drug manufacturer for a specific indication after that manufacturer has submitted a body of research to the FDA supporting the use of the drug for that particular indication, and then it receives that approval. And it's important to note that there's a difference between FDA-approved indications for a medicine versus indications and like when it's actually used. And this is when you hear about medicines being used off-label. Gabapentin is one that comes to mind. It only has a couple of technically approved FDA indications, but it's used clinically in probably 15 to 20 different conditions. So now thinking about when should certain medicines not be used. So there's various disease states or other medications somebody could be taking, whether they're pregnant, how old they are, or even their gender. So there's a lot of different factors to take into consideration when a drug is selected. So let's think a little bit about adverse reactions and side effects. So side effects are an expected reaction. Okay, it's something that we know is pretty likely to happen, and it's often because of how the medication itself is working. Because if I want to change a certain thing about the body, oftentimes there's other instances that is taking place as well. So let's give an example about this. So SSRIs, or selective serotonin reuptake inhibitors, are one of the main antidepressants that we use. Okay, an adverse reaction that we need to be aware of is in the teenage and kind of early 20s population. Taking these antidepressants can actually make someone suicidal, which is ironic given why we're giving it. So if someone were to take an SSRI and become suicidal, that would be considered an adverse reaction because that's different from what we expect. That's not the goal here. A side effect is something that happens because of how the medication works. So that would be an example of like nausea or headache in the SSRI example. So dosages, age and weight are a big consideration. Typically kids over the age of 12 are given adult doses, but it's always something important to double check. Appendix A in your book goes over common medical abbreviations used in prescribing. Where I'm at, we do predominantly electronic prescriptions in order to help reduce some of this confusion, but it's important to be aware of the different abbreviations. So a couple of considerations specifically for athletes. So the drug that we may choose to use is not always a viable option because it might be banned during competition. Okay, and so hopefully as a prescriber, they would be aware of the person's status as a competing athlete and would choose other medications, but you guys are another line in order to help with this. Drug of choice needs to be approved for competition and is non-sedating. It's also important to keep in mind as you counsel these athletes about potential drug misuse. Oftentimes people think that more drug, if this drug is good for this condition, more of it must be better, but that's not the case. For instance, ibuprofen, anything really above 400 milligrams per dose gives you a very slight, like marginally improved anti-inflammatory effect, but it also greatly increases the risk of GI problems with it. So taking 800 milligrams doesn't really get them that much more than 400 milligrams. And then always keep in mind how much self-medicating people are doing. You can get a lot of medicines over the counter, and although they do have instructions, it's important that people take them in doses that are recommended as opposed to just trying to take more and more.